Good morning. Today we are going to read the osteomyelitis and septic arthritis guidelines, which is very important and crucial in the clinical MAR-CBCH exam. Okay, Bismillah. Recognition and assessment, symptoms and signs. First of all, it's going to be fever or history of fever, not always at presentation, loss of function, limping, pain in bone or joint. This could be localized, often ends of long bones, constant, increasing, pain site often misleading. For example, hip infection more often than not presenting with knee pain. Okay, a restricted range of movement, soft tissue swelling, buoyant tenderness of bone, effusion, reluctance to sit or stand, impaired ability to bend due to pain. Okay, we have a notes in this box saying above symptoms and signs are suggestive of osteomyelitis or septic arthritis in absence of clear history of obvious trauma, respective of WBC, CRB, ESR, and fever or radiological appearance. Keep nail by mouth, bending, orthopedic aspiration, or surgery. So all the above symptoms and signs may lead you to a diagnosis of osteomyelitis or septic arthritis. Regardless of the WBC count, CRP or ESR, and fever or radiological appearance, it's only clinical presentation. Okay, so in any way, you will keep the child nil by mouth for bending, orthopedic aspiration, or surgery. All right. Let's move to the next set, a previous history. So what you're gonna ask in the history? Ask about the duration of symptoms, injuries, fever, antibiotics, or anti-inflammatories, hemoglobinopathies, for example, thalassemia, sickle cell disease. So we keep all this in mind, the duration, onset course and the duration, any injuries so far, fever, antibiotics have been given, antipyretics, anti-inflammatories. Keep in mind the hemoglobinopathies such as thalassemia, sickle cell disease. Okay, what are the urgent investigations you need to do? Full blood count, ESR, CRP, blood culture before antibiotic, minimum 4 ml older children, 2 ml neonate. If cause of fever uncertain, collect other specimen, for example, urine. Keep in mind the UTI, urinary tract infection. Okay, if in any case of fever. Collect other specimens, for example, urine, for culture before antibiotic. If immunocompromised, penetrating injury, or failed primary treatment, also anaerobic and TB, fastidious organisms and fungal culture as well. Okay, so if the child is immunocompromised, he has penetrating injury, you have started already the traditional antibiotic and there is no any improvement, think about the anaerobic infection, think about TB, think about fungal infection as well. Okay, what's your differential diagnosis in here? We have transient synovitis of hip, the age between 4 and 10 years old, usually can weight beer, history of upper respiratory tract infection last 2 weeks, non-toxic, temperature less than 38.5, CRP less than 20 milligram per liter. Okay, so this is transient synovitis of fever. How you can recognize it? Okay, what's about fracture or trauma? There would be for sure history of trauma. There will be bruises, and no fever. Lyme arthritis, epidemiology. Of course, you have to ask about the travel, history, usually affecting the knee, and no fever. Okay, Baker's cyst. Baker's cyst. CRP will be less than 40 milligram per liter. There will be the other differential. We have cellulitis. Erythema precedes pain, skin tender and edematous. Chronic recurrent multifocal osteomyelitis. So this is going to be insidious onset, pain worse at night, unusual site, for example, clavicle, jaw, and scapulae, associated with palmoplantar pustulosis or psoriasis. Palmoplantar pustulosis and psoriasis. Okay, so this chronic recurrent multifocal osteomyelitis. Okay, think about as well hematological malignancies, prominent systemic complaints, for example, fatigue, anorexia, and weight loss. What about bone malignancy or neoplasm? Diaphysis or flat bones. Pain worse at night. Okay. Juvenile idiopathic arthritis onset is going to be over weeks and affecting symmetric joints. SLE, for sure, it's going to be fever, weight loss, rash, and ulcers. Reactive arthritis, 2 to 3 weeks after gastrointestinal infection or genitourinary infection. So that's reactive arthritis. Post-streptococcal, 3 to 14 days after streptococcal infection. It's going to be polyarticular response to non-steroidal anti-inflammatory drugs. Okay, osteomyelitis. Ultrasound joint, plain X-ray, anteroposterior and lateral of affected part. If surgical explored or needle aspiration, tissue or pus for gram stain and culture. Okay, for investigations for osteomyelitis, I guess in here we will do the ultrasound for the joint first. We need to do plain X-ray, anteroposterior and lateral as well. If need surgical exploration or needle aspiration, any tissue obtained or any pus obtained from the site of lesion, we send it for gram stain and culture. Septic arthritis, for sure, we'll do ultrasound joint as well, aspiration of joint for gram stain and culture. Interventional radiologist or orthopedic registrar or consultant. So who is going to do the aspiration of the joint? It's not me, it's not you. It's going to be interventional radiologist or the orthopedic registrar or the consultant. For sedation and analgesia if needed, pediatric registrar or on-call pediatric anesthetist. Okay, so keep these names in your mind. It's very important to know what's your job, what's the other team job. Okay, further investigations. Before as soon as possible must be within 36 hours. Okay, so all the following investigations need to be done as soon as possible within 36 hours, not later. Okay, if plain X-ray normal, so if we have done already plain X-ray for the affected joint, okay, and we have got this plain X-ray normal, infection clinically localized and urgent MRI is available. Consultant pediatrician or orthopedic surgeon to authorize urgent MRI of bone. Okay, so we have many options in here. We can move according to these options. If you already done plain X-ray for the affected joint and this plain X-ray was normal, but clinically you have infection, you have signs of inflammation, you have seen affected joint, and urgent MRI available. You have the facility in your workplace to ask for MRI, to do MRI. So you have to consult your consultant pediatrician for that, or the orthopedic surgeon. Consult pediatrician or orthopedic surgeon to authorize urgent MRI of bone. It's not you, okay? If deep sedation or general anesthetic required, contact on-call pediatric anesthetist. Okay. The second option that we have, if plain X-ray normal, infection clinically localized, and MRI not available, request ultrasound scan to look for fluid and synovial thickening in knee and hip joint. Okay, so the first option was we have normal plain X-ray, clinically we have obvious infection, and we have MRI available. So we're gonna consult our pediatric consultant or orthopedic surgeon for that. Second option, if we have a normal plain X-ray, infection clinically localized, and I don't have MRI facility in my workplace, so I have to request ultrasound scan for the joint to check is there any fluid effusion, is there any synovial thickening in the knee and hip joint. If localizing signs poor or possible multifocal infection, whole body MRI, discuss with consultant, pediatric orthopedic consultant. So the third option we have in here, if you have localizing signs not obvious for you, you cannot detect where's the focus of infection exactly in the bone. You expect that there's a multifocal infection. So you will request after consultant, discussion with your consultant, you ask for whole body MRI with your consultant, and you have to discuss that with your consultant first. If cardiac murmur or multifocal staff or yes, request echocardiogram. If you have got any murmur in the heart with a joint inflammation, both are exist together, just think about doing echo for the heart. Okay, what about the immediate treatment? If you got any case suggestive of osteomyelitis or septic arthritis, the first thing that you do that you have to admit this child. Nail by mouth and maintenance IV fluid. Bed rest, refer immediately to orthopedic and on-call pediatric registrar for urgent assessment. So admission, NBO or nail by mouth, okay, complete bed rest, and refer immediately. You have to refer immediately to your orthopedic, to the orthopedic or on-call pediatric registrar for urgent assessment. Early involvement of on-call consultant orthopedic surgeon. Okay. What about the antibiotic choices that we can think about in these cases? CBNF for neonatal doses. So you have to have a look on the BNF all the time, most of the time. You cannot you cannot memorize the dose out of your brain. It's not the good practical way. It's illegal. So you have to check the BNF all the time in your workplace. Okay, so first of all, commence following surgery unless it will take more than 4 hours from admission to get to theater. Okay, so for the antibiotic, so you will start the antibiotic for this patient following surgery. If you have got like aspiration or cleaning or cleaning of the a place localized where there's a localized infection or a bus or whatever, you have to start antibiotic immediately after the surgery. Okay, so as we said, we have to start antibiotic immediately after the surgery, unless it will take more than 4 hours from admission to get to theater. Okay, if it passed 4 hours from admission to get to the theater, so you not start antibiotic at that time. Okay, severe sepsis with organ dysfunction. Severe sepsis with organ dysfunction. That's mean hypotension, oxygen requirement, GCS less than 12, platelet less than 80, and creatinine double normal and abnormal LFT. Okay, again, if we have severe sepsis with organ dysfunction in form of hypotension, oxygen requirements, GCS less than 12, platelet less than 80, creatinine double normal, abnormal LFTs, after blood and urine culture taken, commence cefotaxime 50 milligram per kg, 6 hourly, high dose maximum 12 gram per day, IV over 3 to 4 minutes. Okay, so that's if we have severe, like toxic patient, he got organ dysfunction, septic shock as well, hypotension, Roscoe scale low, platelet low, the creatinine level is high, and abnormal liver function test. So after taking blood, you have to take blood and urine culture first, and then start immediately cefotaxime 50 milligram per kg 6 hourly, IV over 3 to 4 minutes. If we have no organ dysfunction, there's no organ dysfunction, as soon as possible, must be within 4 hours. Okay, so if there's no organ dysfunction, you have to start antibiotic as soon as possible within the first 4 hours of presentation. The neonatal dose, we have to check the BNF. It's very crucial. If aged less than 3 months, cefotaxime 50 milligram per kg 6 hourly, or ceftriaxone 50 to 100 milligram per kg daily. Aged 3 months to 5 years, cefuroxime 50 milligram per kg 8 hourly. If aged more than 5 years, flucloxacillin 50 milligram per kg IV 6 hourly. So that's the age group. So you can organize your thoughts. You have to check BNF all the time. Double check the dose once again. You'll be in the safe side. Targeted antibiotic therapy. If organism identified, use narrowest spectrum possible with good bone joint penetration. Staph aureus sensitive to flucloxacillin 50 milligram per kg 6 hourly IV. Penicillin allergy substitute for flucloxacillin. If there's history of rash, you swab from penicillin to cefuroxime or ceftriaxone. History of anaphylaxis or high risk MRSA, clindamycin high dose, bomb blast injury, which are war injuries. You see the Public Health England advice. There's a link over here to have a look on that. All right, let's go through the antibiotic once again because it's very important. Try to check the BNF most of the time to double check the dose. As we mentioned, that we commence the antibiotic after surgery unless it will take more than 4 hours from the admission to get to theater. If there is severe sepsis with organ dysfunction, you take blood culture, uniculture, you start cefotaxime in a high dose, 6 hourly, 50 milligram per kg, IV over 3 to 4 minutes. If there is no organ dysfunction, it's better to start within the first 4 hours. Neonatal dose, you have to check BNF for that. Less than 3 months of age, you start cefotaxime, 50 milligram per kg, 6 hourly, or ceftriaxone. So cefotaxime or ceftriaxone. 3 months to 5 years, cefuroxime. More than 5 years, flucloxacillin. You have to be targeted in your antibiotic therapy. If organism identified, you know already the organism, you narrow your spectrum. Staph aureus sensitive to flucloxacillin as well. Penicillin, if there is penicillin allergy, you have to substitute for flucloxacillin. If there is history of rash after commencing the antibiotic, cefuroxime or ceftriaxone, instead of flucloxacillin, you give cefuroxime or ceftriaxone. If there's history of anaphylaxis to or high risk of MRSA, clindamycin high dose. Bone blast injury, you check this link. What about the analgesia, which is very, very, very crucial in here? Bed rest, analgesia, admission, bed rest, and analgesia, these 3 important points. If necessary, initially to allow splintage, use morphine IV. We need in here very strong painkiller, which is morphine IV after splinting the affected limb to minimize the movement and minimize the pain. Elevate and splint affected limb. Plaster back slab for peripheral joints. Wrist and skin traction or a pillow for proximal joints. Okay. So for the analgesia, you have to splint the affected limb and use IV morphine. So according to the pain, we have mild, moderate, and severe pain. We have guidelines for the analgesia itself. We can go through it another day. So in here, we're going to elevate and splint affected limb. Plaster back slab for peripheral joints. Wrist and skin traction or a pillow for proximal joints. Surgery. Ask parents to stay with the child until consent obtained. Resuscitate if severe sepsis. Emergency theater to be alerted as soon as possible. Contact anesthetic office to arrange pediatric anesthetist. Orthopedic registrar to book patient onto suitable list. Consultant pediatrician and orthopedic surgeon. So this is the team. You will contact the emergency theater to be alerted, the anesthetic office to arrange a pediatric anesthetist for that, orthopedic registrar to book patient into suitable list, and consultant pediatrician and orthopedic surgeon as well. Subsequent management, inform pediatric orthopedic surgeon and consultant pediatrician. Those are going to be your team, your consultant, side by side. Uncomplicated septic arthritis. Okay, for subsequent management, we have complicated septic arthritis and uncomplicated septic arthritis. If you got uncomplicated septic arthritis, what that mean? Not complicated by associated osteomyelitis. So what you're gonna do? Further management for this patient. Aspirate or drain joint in theater. Request long line insertion under general anesthesia and repeat any blood test required. If discharged for hospital at home IV treatment, change to ceftriaxone if sensitive or no organism isolated. If treatment started within 24 hours of first symptoms and clinically improving, discuss with consultant about changing IV to oral antibiotic after 72 hours. If recovery of joint movement, absence of pyrexia after 4-hourly monitoring for 48 hours, WBC is less than 11, CRP and ESR falling on 2 successive specimens for 24 hours apart or more. If agreed by orthopedic consultant, give oral antibiotic to complete treatment. No organism identified. That's co-amoxiclav. Check the BNF as well for the dose. Organism identified, narrow spectrum with good bone penetration. Okay, let's move the last page of this guideline. If Staph aureus sensitive to flucloxacillin, if Staph aureus sensitive to flucloxacillin oral high dose, if capsules tolerated, or co-amoxiclav double dose, if can only take suspension. Allergic to penicillin, so clindamycin oral. Stop treatment only if SCRP is normal. Agree duration of treatment with orthopedic consultant depending on individual case. Uncomplicated usually 3 to 4 weeks, except hip, it's going to be for 6 weeks. Okay, let's go through the treatment again, subsequent management. So we said that uncomplicated septic arthritis, which mean not associated by osteomyelitis, aspirate or the joint and theater, request long line insertion. If discharged home, you continue treatment IV at home. We change to ceftriaxone if sensitive or no organism isolated. And if treatment started within 24 hours of first symptoms and clinically improving, discuss with a consultant about changing IV to oral antibiotic after 72 hours if recovery of the joint, movement improved, no any fever not anymore, after 4-hourly monitoring for 48 hours, WBC count less than 11, CRB and ES are falling on 2 successive specimens 24 hours apart. If agreed by orthopedic consultant, give oral antibiotic to complete treatment. No organism identified, discharge on co-amoxiclav, double dose, double check the BNF for that. Organism identified, narrow spectrum with good bone penetration. If Staph aureus sensitive, for sure, you will discharge him on flucloxacillin, oral high dose, or co-amoxiclav as well. Allergic to penicillin, you give clindamycin orally. You stop treatment if the CRP is normal. The uncomplicated septic arthritis usually takes 3 to 4 weeks treatment on antibiotic, except if you have a hip joint infection, that will be more longer for 6 weeks. Early presenting osteomyelitis. If IV antibiotic starts within 24 hours of onset of symptoms with a good clinical response as above, follow uncomplicated septic arthritis. Okay, established osteomyelitis or complicated septic arthritis. So presentation, for the presentations more than 24 hours after onset of symptoms or partial treatment with oral antibiotic. Formal debridement in theater with insertion of Hickman line. Antibiotics, IV, as above. Discuss with orthopedic consultant about switch to oral antibiotic after 14 days. If afebrile, pain-free for 48 hours and CRP less than 20. Continue oral antibiotic until all inflammatory markers are normal and clear evidence of healing established on radiograph. Discuss duration of antibiotic with orthopedic consultant in each case. Okay, septic arthritis or osteomyelitis. For example, deteriorating Okay, septic arthritis or osteomyelitis, deteriorating condition, failure to improve within 48 hours. That's mean this patient is having osteomyelitis or complicated septic arthritis. He is not improving within 48 hours of starting the antibiotic. So in this case, inform orthopedic team for exploration to drain pus, review culture result, discuss with consultant microbiologist and pediatrician, arrange for repeat blood cultures. If culture positive, target antibiotic therapy, complete or repeat any investigations listed above, consultant pediatric medical and orthopedic review, exclude important differential diagnoses. For example, it could be systemic inflammatory response as seen in juvenile chronic arthritis. It could be transient synovitis associated with intercurrent infection. It could be acute leukemia, septicemia, multifocal disease, endocarditis, Ewing sarcoma, continuing problems with local sepsis, return to theater for further debridement, and insertion of Hickman line. So that's the very sophisticated management for the septic arthritis or osteomyelitis. If there is no improvement within 48 hours, so you inform basically your team, the orthopedic team, to drain this pus, review the cultures so far, discuss with the consultant microbiologist and pediatrician, repeat blood cultures over again. If culture positive, target antibiotic therapy, complete any uncompleted investigations so far, consultant pediatric medical and orthopedic review as well. Think about other differential diagnosis. If there is no improvement, it could be systemic onset GIA, it could be transient synovitis with other infection, it could be malignancies, acute leukemia, septicemia, endocarditis, Ewing sarcoma. Put all this in your mind. If there's ongoing local sepsis and pus reformed again, so return to theater for further debridement and insertion of Hickman line. Monitoring treatment. So how I can monitor the treatment? I have to check the peripheral color, warmth, movement of affected limb hourly for first 4 hours, then 4 hourly for the 24 hour. Respiratory rate, pulse, temperature 4 hourly. If not improving, repeat blood cultures all over again. Additional imaging for metastatic infection, assess for deep vein thrombosis, as well as he is not moving his limb for a while. Discuss with infectious disease or microbiology about broadening antibacterial spectrum. So that's the guideline for septic arthritis and osteomyelitis. I hope you enjoyed it. We will read the analgesia guideline next time, so we can cover the most of this topic. Thank you for watching.